Hello everyone, and thank you for listening to this web conference. We hope you are all doing well despite this difficult period for public health due to the COVID-19 pandemic. Speaking about health, let me introduce you to our research subject, namely health data management in a complex system. This study was conducted before the COVID-19 pandemic. We chose to keep the original version of the article for this conference, but an extended and actualized version will be published in the months to come. Do not hesitate to contact us if you would like us to send it to you. The management of personal data, with the recent enactment of the General Data Protection Regulations, has become a crucial and strategic issue for organizations. In the healthcare sector, where respect for medical privacy is closely linked to the dissemination of personal records for patients, data has to be managed with great care in order to limit the risk of unfortunate disclosure or data loss. The current French public health field tends to evolve to collaborative working methods. For the past 10 years, French health authorities have been witnessing the emergence of some new healthcare and public health organizations. We have also been witness to the exponential growth of hybrid organizations, made up of both medical and paramedical staff, attesting to the growing complexity of health organizations. This is particularly the case for multidisciplinary or multi-professional care houses, or MCHs, with 910 institutions active in France as of March 2017, compared to only 240 in 2013. These organizations are complex because of the number of interacting actors they involve. They also tend to rely on the notion of sharing and circulating data, especially health information about patients. In doing so, they tend to improve patients' healthcare and health monitoring. Does this new type of institution pose some risk to private health data policy? And as they are composed of many multidisciplinary actors, for instance, medical, paramedical, or administrative professionals, do they not increase the number of possible accidental disclosures or the risk of losing confidential data? In this presentation, I will first present the study background. Then I will justify the case and methodological approach we chose for our study. 3 parts will follow. The first will be dedicated to the analysis of data management processes, the second to organizational processes, and the third to general lack of use of the National Digital Health Record. First, some background information on the study. It was conducted in the Département des Landes, located in the southwest of France. In 2014, the population density of this area fluctuated between 2 and 45 inhabitants per kilometer squared, with an aging index among the highest in the country. In 2015, 31.5% of the land population was over 60 years old. In addition, this area also has a medical demography and a density of specialists lower than regional and national averages, as well as a very small number of health organizations. According to the Regional Health Agency, 1/3 of liberal general practitioners were over 60 years old in 2017. This fact leads us to question whether or not the region will undergo sufficient turnover of medical practitioners in the years to come. RHA demographic patterns of healthcare have been measured in this region, such as white areas or towns located more than 50 kilometers away from hospital emergency services, or medical desertification, which are unattractive territories for young medical professionals, or fragile areas, those with unequal distribution of health professionals. Due to these factors, the area of the Landes is now facing an exceedingly unfavorable public health context. The exploitation of personal data remains a sensitive topic, as it directly affects the privacy of each individual, especially when it comes to medical data. In complex systems, such as multidisciplinary care houses, there are several issues related to the management and to the protection of health data. From an organizational point of view, it is essential to set up procedures to secure access to data. With the multiplication of MCHs, the French health sector must now face a multitude of risks related to data, which require close scrutiny of each elementary activity. These organizations are the result of a clustering of health professionals who, until now, had been working alone. The various stakeholders in the project have to develop fundamental procedures for collaborative work. Professionals in this new context must demonstrate that their services are delivered in a secure environment. This environment helps to control the risks. The notion of attractiveness is very important here. Offering a young professional an isolated practice in a small town does not have the same appeal as a long-term position in a multidisciplinary institution, in which he or she could be supervised, advised and supported by administrative services, surrounded by colleagues and supported by financial and material resources. Collegiality and plurality of perspectives make the medical practice both more reassuring and richer, especially at the beginning of a career. This is the appeal offered in general by MCHs. Moreover, Landes is the largest region of France, with a mainly rural territory, and offers most of the current and forthcoming public health services we presented a few minutes ago. 30 people are involved in the daily operations of the MCHM. They are all subjected to the institution's collective agreement, in which respect for medical confidentiality is clearly enshrined. Data is managed and stored on a specific medical database software called WEDA-19, which is also used by the surrounding external collaborators, such as pharmacists, specialists, and hospitals. The choice to use the same software aims to facilitate the medical and administrative aspects concerning the caring continuum. Each member of the MCHM has secure access to the software. However, MCHM members do not have the same level of access to patients' records. Doctors, as well as their secretaries, have full access to the information concerning patients. Files, auxiliary session schedules, secure messaging, etc. This is justified by the need for cooperation between practitioners and their secretaries, for the smooth functioning of the MCHM, and for the good of patient care. Then come the paramedical staff, with access to data tailored to their specialty. Their access is conditioned by the needs of their activity. A physiotherapist, for example, will have access to the patient's x-rays and related prescriptions, whereas a nurse will have access to history, data obtained from specialist consultations, blood test results, and vaccine records, depending on their needs. These professionals do not have access to the content of visits, letters, prescriptions, unless specifically agreed with the doctor. The accreditation of external professionals for data access is aligned with the accreditation practices of the institution according to the needs of the patients, the activity, or the specialty of the practitioner. Collaborative patient follow-up is governed by multi-professional consultation meetings, planned or impromptu, attended by all the professionals involved in the presented case. Each meeting is documented, stored via WEDA, and only accessible to the concerned professional. At the beginning of the survey, the goal was to identify the organizational model and rules implemented by the MCHM's team, especially those concerning working processes and data management. To do so, a qualitative approach was chosen. This method was selected for its ability to investigate the practices and interpret the results. It holds that the, quote, confrontation with the corpus is a necessary condition for the perception of social practices, end quote. The goal was also to confront the different points of view concerning the organizational processes. The potential divergences and discordances regarding the position can be highlighted. And concerning data privacy management, the heads of the MCHM were interviewed. They had to explain their choices in terms of data management policy, of coordination put in place, and of emergency plans in case of unfortunate disclosure. An organization can be defined as a set of recurring transactional programs that constitute transactional flows. They are driven by a set of convention and rules in a given context. For its proper functioning, given the complexity of transactions, it is essential to give access to the right information at the right time to make a selective transmission of users in order to fight against misinformation, overabundance, and deviant uses. The principle of data management is based on the ability of actors to select information and analyze it in such a way that it is only disseminated to its legitimate recipients. The ethical processing of information seems to be the starting point of the MCHM's data management strategy. Béranger defines it as a mechanism for the interpretation of data by a person and organization with the goal of assigning meaning to it and extracting value from it. By paying attention to information and analyzing it, the heads of MCHM extract value that allows them to define use cases for data handling, such as censorship, global dissemination, limited dissemination, among others. In the medical sector, it is fundamental to establish a reflection on personal health data through an ethical prism in order to remove doubt and control uncertainties, and to manage the risk inherent to the nature of patients' records. In the MCHM, data dissemination is informed by the profile of the information receiver, ranging from very limited to full access, depending on activity and needs. This improves the security, confidentiality, and protection of such data, as well as the performance of the information management system. By analyzing the data, determining the conditions for sharing and clearly identifying the receivers, the quality of access to patients' personal data is guaranteed. This data processing method leads us to discuss the notion of lean data quality management. Lean School is defined as the search for process optimization by chasing down everything that is inappropriate or superfluous, guaranteeing performance by eliminating waste. This method can be applied to information management in order to analyze the transaction optimization activities. The ethical processing of information we talked about tends toward a very low entropy. A system in which information is transmitted without analysis increases the level of confusion, as well as the slowness of decision-making and the risks of accidental dissemination of personal records. On the contrary, in a complex system such as the MCHM, the implementation of a hierarchy in information management makes the actions of all team members easier and smoother, by only sending the data that will be useful to the staff in the exercise of their activity. This is a kind of lean management applied to information management. This data dissemination method tends towards the goal of zero useless information in order to guarantee both respect for medical confidentiality, i.e., zero information poorly disseminated, the quality of patient care, i.e., zero information missing, and the fluidity of actions, i.e., zero dysfunction linked to poor information dissemination. This information management method seems to be perfectly adapted to the performance requirements of MCHM's missions while benefiting the daily tasks. We're now going to talk about the organizational processes for guaranteeing the quality of data management. In the MCHM, the mobilization of the whole staff tends to improve the process's efficiency. Its management method is based on the involvement of all teams in improving the life of the institution. Meetings, taking into account opinions, professional development, empowerment, etc. This method seems to be similar to the collaborative processes set up within the MCHM, although the institution does not claim any particular managerial method, such as unexpected discussions, weekly team meetings, or festive group cohesion events. This team management aims at analyzing defects and dysfunctions, and then seeking solutions. Emphasis is placed on freedom of speech, professional responsibilities, skills of each individual, and above all, the necessary trust between employees, which is considered essential by all MCHM staff. As Doucet points out, it is essential that the direction of quality action be collegial. This makes it possible, in particular, to respect responsibilities and involve departments. As a large number of individuals have access to the institution's health data, the use of this collaborative and collegial approach is essential to the MCHM. The increase in performance can only be achieved through the collaboration with the departments involved in this approach. And by soliciting and valuing all staff members, the MCHM ensures the fine relationship management, but also encourages professionalism and accountability from each individual. They also do so by regularly reminding them of the need for secrecy and rigor, both informally and informally, especially concerning the performance of their daily tasks relating to patient health records. Transactional relationships then lead to overcome formal/informal oppositions by insisting on their complementarity. Cooperation relies on a clear commitment from each member of the group and is strengthened by trust. In a complex system, each member of the team contributes to the success of the institution's goals. It is up to the leader to make the team understand and adopt these fundamental ethics, rules, and behaviors. To do so, the MCHM holds many meetings, both with the whole staff or with some specific subgroup, such as doctors and administrators only, or doctors and their secretaries. Those meetings allow the team to provide feedback on the implementation of processes and outline all technical or relational issues. It also helps management resolve disagreements before they worsen and help the team work more efficiently. Theoretically speaking, leadership and management must be piloted by a person of influence who, thanks to his or her managerial skills, is able to guarantee effective cooperation and coordination based on mutual trust. The notions of cooperation and trust seem to be interdependent key resources for the management of complex systems. The operational management of the MCHM is based on the involvement of two doctors, who will be referred to as P&T. Their influence is grounded in their legitimacy within the team, gained through their seniority, their involvement in the project, and their ability to organize the run of the institution. The team trusts them. It is a symbolic human capital that the two doctors have accumulated throughout the years. Having the long-term trust of the team gives P&T the ability to engage and influence each member of the group, which helps the team to solve complex issues and aim for an outstanding performance in their work. Let us now discuss the general lack of use of the National Digital Health Record. It should be noted that the National Digital Health Record, in French, Dossier Médical Partagé, or DMP, is not integrated into any of the care management practices of the MCHM. This case study tends to reveal a profound attitude of rejection by MCHM staff, who state that this file is not designed for medical practice. In case of emergency, the DMP becomes counterproductive. Of course, all the information about the patient is included, but it is not sorted or classified. It is up to the user to find the right information, and in emergency situations, doctors simply do not have the time to sort the information. By presenting the raw data, the DMP is not in line with the requirements for efficient data management. It does not fit the infoethical approaches or the lean data principles we discussed, which are the main data management strategies used within the MCHM. More broadly, the DMP raises the need for co-production concerning innovation and the necessary collaboration between producers and users to guarantee the quality of a product or service. Bringing together the documents and data for process governance requires mastering the notion of a system, but above all, acting in a spirit of collaboration with the users. For the DMP to be relevant, it is essential that it be analyzed, organized, and structured in valuable data sets. This work must be undertaken in active collaboration with health workers, patients, and public health authorities so that it corresponds to the work processes, needs, and objectives of each of these stakeholders. In conclusion, the sharing procedures introduced at the MCHM raise questions about risk assessment. During our investigation, it seemed that the process of quality of care evaluation and crisis management protocols were non-existent. It is problematic, as the implementation of best practice crisis management protocols is one of the most important criteria for evaluating quality of care. This is because managing quality within such an institution cannot be accomplished without including risk management practices. Therefore, it seems necessary to study the MCHM in greater depth in order to explore more obscure aspects of its management and to consider a global quality approach in risk management. It would also be interesting to study the management of the MCHM through the notion of emotional intelligence. The price for the lack of emotional intelligence can often end up compromising the very existence of an institution. Whereas quality control and data management rely heavily on rational factors, other elements of an institution depend on human and emotional factors. The study highlights some minor problems, especially concerning a doctor who sometimes awkwardly criticizes his colleagues, doctors and secretaries alike. Until now, it has been resolved quickly and discreetly. This kind of criticism precedes the loss of trust in a team, and the MCHM does not seem to be prepared for this kind of occurrence, because its operating model is predicated on all actors operating in good faith and on their best behavior. Investigating emotional intelligence as a key resource in organizational management could ensure the stability of the MCHM and its staff. And finally, it would also be interesting to investigate, on a larger scale, other MCHs in order to measure up the results of this study with other territorial and technical contexts. The goal is also to consider the utility and feasibility of developing a single working model for all MCHs, especially where data privacy management is concerned. As each MCH has its own specifications, is it possible and relevant to propose a single management model for all of them? Thank you very much.